Tonight, Mr. Randy.
Thank you. You hear me okay?
Yes.
So, as you said, I'm Randy Hanson. I'm an attorney at Grant Works. I do primarily medical defense work, both from a counseling standpoint and then in the event that there becomes a lawsuit, I represent physicians and hospitals across the state and into Minnesota. Many of you I've met before, some of you I've not. And for those of you that have not, congratulations. Usually I'm the last person that anyone wants to have to see. In fact, years ago, it was kind of funny. I had a good friend who was a director of a family medicine residency program who always said, I'm not going to have lunch with you alone at the hospital just for the implication of sitting by you. So I get that. It's sort of like when the risk manager comes or the malpractice defense attorney comes, nobody wants to see that. But we do other parts to it too, and that's really what this tonight is about, and that's to talk a little bit about some of the things that we can do that maybe we don't get into that position where you have to stay meeting. And so that's kind of what we want to do tonight, talk a little bit about documentation, transparency if things don't go exactly the way that we want them to go, and then talk a little bit about some of the things we've learned from cases over the years that have some takeaways. And then the last thing we'll talk about is some of the changes we've seen in North Dakota laws as it relates to practice of medicine. I'm an attorney. I do this full time. I do very little else other than medical work. My wife was a nurse. My brother's a CRNA. My daughter actually was here for a while. She did her third year medical school here. Some of you know, actually, Dr. Billings did her foot at graduation. And so I'm pretty intertwined with the medical community, not just from a legal standpoint, but frankly from a personal standpoint as well. And I get that this is more than just a job. This is a profession, and it has a profound effect on people. And you take your work seriously. And so we want to talk a little bit about how we might be able to help that. So what kind of cases do we see in North Dakota? This is usually good news, bad news, depending upon specialty. So unfortunately, those of you that are surgeons, that tends to be the number one spot that we see. Different kinds of surgery, whether that's general, orthopedic, whatever. Cardiac's number 2 on our list. Third one is emergency room cases. And then we go down the list of cancer. We're one of the rare groups. We don't see a lot of OB cases, and that's a great thing. That's not generally been true across the country. They're seeing more and more of those. And you'll see in the far distant last our family practice in pediatrics. And there's a reason. There is definitely a reason for that. It's not just the risk of what it is that you do. It tends to be the relationships that are developed. And what we see is the people that have relationships with their patient, they're far less likely to get sued. So, for the most part, in North Dakota, we're very lucky to be here in terms of what we see with our patients and with our people. Generally, we don't have jurors that like people that sue their doctors. I've been doing this now for almost 31 years, and I don't know exactly how many trials that I've had in North Dakota and Minnesota, but I'm guessing in this 70 to 80 category. I've been involved in 2 cases in all of that time where the jury has gone against us. One of them got overturned immediately. And I'd love to tell you that this is my baffling brilliance that gets us that. It's not. It has everything to do with the fact that most jurors around this North Dakota area want to give you the benefit of the doubt. They believe in what you do. They believe in the medicine that you provide, and they want to give you the benefit of the doubt when they can. But we have seen some changes. In the last few years, we've seen more cases result in verdicts than we've ever seen. A friend of mine who's a colleague of mine tried a case in Bismarck a few years ago and ended up with a fairly large verdict. I was involved in it indirectly. We got our people out, and there was only one person left, and that did not go well. However, some of the things about this case should probably scare you a little bit, and especially when it comes to documentation, realize how important that is. That case was 12 years old with a child when ultimately the case was brought. Think of how many patients you would have seen over the course of 12 years and try to remember back exactly what happened and even how the standard of care changed over 12 years. It just illustrates the importance of documentation. We also saw, again, in Bismarck, actually we've seen a few in Bismarck, where we reached over $1 million. We've just not seen a lot of that before, and so what we're seeing is maybe a little bit of a change in terms of juries that are actually willing to give an award against a medical provider. We've not seen much of that in the past. I also look a little bit at Minnesota just because we tend to lag a little bit behind, and there's some things that are just crazy. This happened this summer. Orthopedic surgery case out of St. Cloud in Minneapolis Federal District Court. And no, that is not a typo. $115 million verdict. That's on appeal now, and it likely will get reversed, but those kinds of things send some shockwaves through the system. And the difference is that in North Dakota we have a cap on damages, Minnesota does not. One of the things that we're still trying to iron out a little bit is what effect COVID has. You know, you think back a few years ago, there were vigils, there were things that were going on in communities that basically highlighted how both impressed and how much gratitude people had for the medical community. We don't know how long that will last. I think there was a time a few years ago that I don't know that you could have gotten a verdict against a physician or a hospital at that point because everybody was thankful that they had their hospitals in their community. The flip side of that is what we also tend to see is that when you have a downturn in the economy, we tend to see cases go up. As people struggle more economically, we tend to see more cases come to fruition. Some of that maybe they have trouble with medical bills, other things. We expect that we'll probably see an uptick in cases in the next several years. One thing I always like to mention is we'll talk a little bit about documentation and how that relates to medical cases. But one thing I always want to emphasize is how different the legal system approaches problems compared to the medical system. When you look at anything from a review, you're looking at it from a quality perspective. How is it that we look at it? Well, what happened? What was involved? Who was involved? Are there things that we could do better? And in the future, are there things that we can change that will result in better outcomes? Then take the legal system. The legal system looks at it solely from the perspective of what happened and is there someone to blame for it. That's it. And so the two systems don't talk very well together. So what do we see cases coming from? Documentation, number one. There's rarely, I don't know that I can think of any case in 31 years where there hasn't been a documentation issue at the center of the case. Knowing limitations and knowing when to refer, use of resources, and communication both between providers and with the patient. Every case that we have, there's got to be documentation error. And when I say error, it's usually inadequate. The issue isn't usually that it's wrong, it's just not enough. So, you get asked lots of questions all the time about, okay, so what do I need to do for medical records? And I hear from attorneys always talk about it being the legal record. The truth is, it's not a legal record. It's a medical record. And we need to always emphasize that. It's a medical record that basically provides a continuum of care from one party to another. When you have a physician who is taking care of someone, we want to make sure that that whatever's in the record will give that person, the next person, enough information so that they know what you were thinking, they know what happened, and they know what the result was. That's what gives us that continuity of care. I can ask lots of questions about, okay, so I made a mistake. What do I need to do? How can I change the record? Can I make something different? The answer is yes. But understand this. Every change that you make, every keystroke that you make in the computer, somebody in IT has everything that you've ever done, and they can tell what you changed, when you changed it, what computer terminal you were at when you changed it, and what time. All of that is kept, and it's kept for posterity. And so we can pull up what's referred to as an audit trail that literally has a complete synopsis of everyone that has been in the chart and every change that has ever been made in the chart. So just know and understand that as you make changes, that's fine, there's nothing wrong with that, but understand that whatever it is that you put in there first will still be there if somebody wants to discover it. I can ask them, well, I forgot something, should I go back in and add something to it? And my answer is always yes. It's always better if you do it timely. But if you don't, is it okay to put something in later? It is. And we'll get into why that's the case in a bit. What we don't want to do, however, is we don't want to have somebody that goes in and after you know the outcome and you wish you would have done something different. Now you go in and change it and you essentially change what it is that you did. We do not want to do that. You do that and all of a sudden you lose all credibility because now the issue isn't even about what was the care? Was it good care? Was it bad care? The issue becomes, okay, now your credibility's gone. And once your credibility's gone, it's hard to get back. So what do we need to put in the medical record? Well, patient complaint. And make sure that when you put that in as a patient complaint, it is the patient complaint. Sometimes there's a difference between saying patient says this versus just saying this is it, because it gets misinterpreted as that's your diagnosis opposed to this is what the patient said happened. So you want to be clear on what it is that you're documenting for the patient complaint versus what you actually believe to be true. If you're doing a procedure and you need the consent of the patient, we'll talk more in detail about that too. Again, it's important to make sure that that's documented, and not just the form that they sign, the discussion that you have. You want the most important information in there. So if you've got a patient history that matters, we want to make sure that that's there, because we want to know later on, you can go back and look at it and say, okay, I considered that. I knew that to be the case. We want to make sure that your differential is there. And I don't mean you have to put in, obviously you start out with any patient, the differential is a mile wide. But as you go through and you evaluate things, you want to make sure that that thought process of narrowing down the things that you really think are there. And then ultimately, you want to make sure that what you do is there. So if you take steps, if you take diagnostic examinations, if you do a physical examination, the things that you actually do, we need to make sure that we have a record of that. And of course, finally, what happened? What's the result of that? Equally important to what to put in medical records is what not to put in medical record. And number one, always, there's not a lecture that I do, I don't care if it's the medical school, the residents, statewide groups, whatever it is, I always remind people, the record is not a place to criticize another provider. You know, you might get in a referral from somebody else, and you might think, okay, well, that was not done well. There's other places to evaluate that. Make it a part of quality assurance. Make it a part of talking to a colleague directly. Putting it in a medical record is a good way to get yourself in trouble. Why do I say that? Almost invariably, any case I'm seeing where there's been a provider that's directly criticized another provider and there's a lawsuit, it isn't just the one that's being criticized that gets sued. Both of them are. Why? Because plaintiff's attorneys like nothing better than to see everybody crossing the fingers and pointing at each other. It's almost every case I've ever seen where that's happened. Everybody gets sued. Impertinent social information. This one isn't such a medical issue. This is a question that it's amazing how many times I get. So you've got a prime example would be family practice. You get a young lady who comes in with their 3-year-old and their 6-year-old, and they start talking about all of the things that are going wrong, and dad does this and dad does that. Okay, they're there for an ear infection, but we got all these other things that mom wants to talk about. But granted, if there's an abuse issue, that's a different story. That's a reportable thing. However, all of the other background data, what you didn't know when she walked in the door was that mom and dad are in the middle of a divorce. And all of a sudden, you become the star witness of the divorce trial because you put in all the things that mom told you about dad. I've seen that so many times. I get calls of, how do I get out of this? And the answer is, sorry, too late. If it's important to what you're doing, what you're thinking, great, put it down. If it's not, you don't want to do that. And you don't want to apologize in the record. If something happens, there's different ways to do that. That's not the place to do it. Doing the procedure. So after reading God knows how many medical records over all these years, I can pretty much tell you the exact language I'm going to see for every gallbladder procedure. Because it looks identical. Right? I mean, you could just about go down the line on those procedures. That's all fine and dandy, but make sure that you're still doing what you need to do for this patient and not just the rote surgical procedure. This is what I do every time. Here's the risk that you run to that. When you do that, and you just go through the same rote analysis every time, what if there's a difference in this procedure? And you've done exactly what you did every time. You don't have a record of it anymore. I'll give you a prime example, the cut and paste thing. We've seen it, I've seen it, where I had a very, very good doctor, very talented doctor, very detailed intensivist who he used to have 5, 6, 7-page notes, every detail under the sun about the background of the patient. But he was a notorious copy paster. He'd take that 6 pages worth of background information and put it from note to note to note. He did that one time treating a patient. Of course, it didn't matter. It ended up with him on the line. However, we had to deal with the fact that he had 8 or 9 pages of detailed notes in the hospital talking about this infection that was going on in the leg. Except that day 6 he had an amputation. He didn't have a leg anymore. We still had notes describing the leg on day 7, 8, 9. That's the risk you run with that. You got to make sure what it is that you're doing. If you're copying and pasting, be careful about what it is that you're doing. Other little pitfalls of documentation that we see with electronic records. One of my things I hate the most is what I refer to as checkbox items, where sometimes you get in that mode where the computer runs the show. You put in something and the computer dials up all of your possibilities and your drugs and everything else. And sometimes you forget to practice medicine because the computer's already got it done for you. And probably seen more in nursing than we see it on the physician side of things, but we need to make sure that you're still doing the critical thinking that you need to do as a physician or provider. Inconsistencies. So I talk about inconsistencies in detail. That's easy, right? You got a hemoglobin of 7 and the lab came back at 4. We don't have consistency of what it is that the detail is, and it can result in mistakes. The analysis part is different. The analysis is, okay, you're taking care of a patient longitudinally. You've seen them in the hospital for 2 or 3 days, or you've seen them in the clinic, and now they're coming back a week later. Go back a week earlier, you've got one idea about what happened, and all of a sudden you come back the next day or a week later, whatever it is, and now you've got a different idea. If that's the case, we need to make sure there's an explanation for why, right? Because now all of a sudden, if you got one thing going on now you got a different thing, and there's no explanation, it's hard for us to say, okay, well, what were you thinking that changed your mind on this and why? We commonly see this during the whole care not documented, care not given. It's routine in every case that I try that I have to explain that that's not reality. And I fully recognize there's the reality of practicing medicine. You don't have time to write down or dictate absolutely everything that you think you're doing. And you don't have to. But if it's important in your thought process and important from how you're taking care of the patient perspective, that needs to go on the record. Not everything has to, but those things really do. Timing of dictation, this one, of course, is one of those things that doesn't go over well with some people. We have people that are good at dictating, that get it done right away. There are people that are okay at dictation, they get it done at the end of the day, and then there are those that the medical staff people are constantly hounding because they haven't been done in weeks. I can tell you from someone who has to go in and defend doctors, not getting it done for 2 or 3 weeks is a problem, because everybody can point to the fact that if there's any inconsistency at all, it's easy to look at and say, well, how are you going to remember 2 or 3 weeks later what it is that you saw or what it is that you did? And most people are going to nod their head and agree, oh yeah, I would remember that either. So to the extent that you can do it, again, I recognize the pragmatics of practicing medicine, but to the extent that you can get it at least within a day or a day or two, it's just so much easier to defend than it is a week or 2 or 3 weeks later. Another one I like to bring up is the technology issues, and some of that is because we're a little bit lackadaisical when it comes to documentation with technology. So one of the things that we know is we have blood pressure machines and heart rate monitors, and all these things feed directly into the record. We know what they are. And so if we're inaccurate about what it is that we do, whatever gets put in is going to be discordant with what the actual values are that get automatically brought in. And the same is true with respect to emails. Sometimes you might have a quick email or a text with another colleague. Understand, even if you delete that, it's probably not deleted. It's somewhere in the bowels of the system that if somebody issues a request for documents later on, will be found. And we're all guilty of that. You know, if you're going to sit down and do a formal letter, you're probably real careful about how it is that you draft it. How many of us draft a text and use that same level of review? Probably not. I know I certainly don't. You need to think twice about what it is that you're putting, especially if it relates to patient care, because some of these things can come back and be reviewed. So why are the records as important as they are? We spend a lot of time talking about documentation. Why is it that becomes such a big deal? Well, when you're talking to a jury, they're looking at what it is that your records are, because they recognize that you've seen lots of patients, and all the details of those patients you're not going to remember fully 1, 2, and 3 years later. Or, as we talked about in the first case, 12 years later. That's the reality of how these cases work. They don't happen quickly. Most oftentimes, it's about a year and a half to 2 years before they're brought. And then it can take a year to 2 years and up to 3 years for them to work their way through the system. By the time you get to actually having to remember it and appear before a jury, it can be 4 or 5 years down the road. So remembering all the details of everything that you've done, not so easy. More importantly, it goes to how these cases develop. So anyone that's ever seen these trials, so I will tell you this, those of you that have never been to a trial, watching it on TV is a little different. So you see a courtroom drama on TV, and you see the entire trial in 15 minutes. In a real trial, it's a week to 2 weeks long. And here's the deal with it. So when we bring witnesses on, the plaintiffs go first. They bring their people on. Undoubtedly, it will be emotional, lots of tears, not much detail on what the medicine is, other than nobody seems to remember anyone actually told them anything. It's always amazing to me, we have so many safeguards along the way for informed consent issues. And yet, every time I have a surgical case and I ask the patient, well, didn't they tell you about this? No. Nobody ever told them there were any risks at all of what happened. That's the perception that they have. And so that comes out first. But they can only hear it once. So this jury they'll hear people for 2 weeks. You can ask the question once under the rules, and that's it. They don't get a transcript that they can look to evaluate. So when they go back and they deliberate a week and a half or 2 weeks later, they have to go by whatever their memory was of what got said at that point. Okay? Then we go, and we turn it into a factual thing. We teach. We teach them what medicine is. We teach them what happened. We show them the records. We take them through from beginning to end, and we teach the medicine. What I typically call jury residency 101. That's what we do. And they get an opportunity to hear you, and they get an opportunity to hear our experts talk about what happened, again, once. Then they go back to the jury deliberation room, and they have to decide who they believe. They have to decide what happened. And so you've got this emotional account from the plaintiffs that they heard probably a week and a half ago. Then they've got our testimony of here's what happened and here's the medicine they heard over a course of 3, 4, 5 days. And you have 9 people then sitting in that room that are all collectively talking about what they thought they heard throughout that time. What's the difference with the medical records? The difference with the medical records is they get to take that back to the jury room. Okay? All they can do is remember what you said. But they can take that entire chart back to the jury room, and anything that they thought they heard, they can weigh against the actual document. That's why the medical record becomes so important. Because anytime they have a question as to what happened and who was right and who was wrong, they can go back to that medical record and they can look at it. And as a result, when we talked about that, go back a step. As a result, because they can take that back, that's why I always say even a late note is good. Because even though it may be a late note, it may not be as credible as a note that was done at the time, it's still something that they can take back to the jury room, which is better than just trying to figure out what you said 3 days ago or 5 days ago. So talk a little bit about some of the cases we've seen and how documentation impacts that, some of the takeaways. So here you've got a laboratory, patient was prepped and draped in the usual manner, blah, blah, blah. Like I said, could probably repeat that almost verbatim. This was done by a first-year surgical resident. Particularly note is the separation of the common bile duct, obviously mistaken as the biliary duct by the prior surgeon. The patient should have had a flow recovery in several days. Well, now we need a real life procedure and I've scheduled the patient to fail. So, what should he have said? Should have said, here's what I encountered, this is what we did. We really didn't need to say, well, you obviously screwed this one up. We obviously mistakenly saw this. That's the takeaway. Again, we don't want to criticize another provider of the record. Even if you encounter something that's a problem, talk about what it is, talk about what you're going to do. We don't need to criticize or comment on the prior care. This is the discussion about inconsistency of analysis. Okay, so here you've got orthopedic surgery. You got a 24-year-old with a tib-fib fracture, comes in to be reduced. In August, in the clinic, patient would be casted initially with no weight bearing. Patient's congenitally small intramedullary canal makes it extremely inadvisable to place an IM rod. Then comes back a month later. Same orthopedic surgeon. Well, due to the youth of the patient and the likely activities, I'd recommend compression plating or use of, guess what? an IMR. So if this was really a congenital problem, how come all of a sudden we have a completely different analysis than we did a month ago? And we have no explanation in the record for why. Not surprisingly, in that case, we saw giant billboards of these two records up side by side to try and point out the inconsistency. So here's another one. So you had a surgeon involved in a procedure. During the surgery, things started going bad. And the surgeon came out of the procedure and dictated the note. The patient had died on the table. And in the note, basically referenced that he thought that what was going on for 15 minutes. Seemed like 15 minutes, right in the medical record. When we checked the anesthesia note showed specifically that it was true. What's the takeaway from this? We're all human. You have a bad outcome like this. Not many times you see a patient that literally dies on the operating table. And before you dictate, you might want to collect your thoughts a little bit, get your own emotions in check, because sometimes what seems in reality may not be. You want to take a deep breath and step back before you dictate in those circumstances. So here's the opposite part of a different case also involving an IMR orthopedic surgery. This is the part where informed consent wins the day. So in June, believe that IMR would be the best option available, discuss the risks and benefits of the procedure, including the risk of death, thrombosis, emboli, risk of infection, risk of anesthesia, and loss of limb. Patient understands and elects to proceed. Then later on, when we did have a bad infection, goes back in and has to deal with the complications of that. When we won that case, and when we talked to the jury said specifically, we saw and heard the doctor talk about what he knew were risks of the procedure. And we saw in the note, he specifically talked about infection. So when he had the infection later on, we knew from the note that documentation showed the discussion had been had. And we felt like that was in fact a known risk and complication. The patient knew and understood what he was getting into, and he accepted that. And as a result, they did not find that the doctor was negligent. This one's really more of a nursing issue, but it also has a takeaway for physicians. So here you've got a NICU case, patient is desatting, you've got a baby desatting, they're given oxygen, it's just not helping, and so nurse calls the physician calls and updated regarding a drop in oxygen saturations, requested that he come in and see the patient, but he instead increased the oxygen level, ordered RT to evaluate the patient, concerns remain as to oxygenation. So the takeaways from this are twofold. One, we don't look like we're probably communicating very well because now we have a physician in the record that looks like they're not willing to come in. The second thing is we also have a nurse who recognizes there's still a problem, but doesn't do anything about it. And so we have kind of two problems with that, right? We want to make sure that when you do documentation that you're not creating more problems than you're helping. So, we had a case not too long ago where we had an ER patient who came in with kidney stone problems, had a history of severe anxiety and depression, history of asthma-like symptoms, reported an NSAID allergy but really had no proven NSAID allergy. Initially gave Dilaudid in the ER and tried to avoid NSAID. She became violently ill, and so they had a discussion with the patient, decided to give her Toradol. Watched her in the ER, no reaction whatsoever. She went out, and a long story between that time frame, but essentially claimed that she went into anaphylactic shock. Well, as it turned out, she was never in anaphylactic shock. She was having a panic attack. What the problem was is that we had an ER record when we came back in. This is that discussion about make sure that you say a patient says as opposed to this is what actually was happening. We had an ER record that instead said patient in anaphylactic shock, when what it should have said was patient thinks she's having anaphylactic shock. We know the air doctor indicated anaphylactic shock, give her some Ativan and she's fine. So clearly she was never in danger. However, that was of course splashed across the records. So aside from documentation, the other big part of this is communication in general. And I always tell everybody that we lecture to this: every juror is a patient. Okay, you have 9 people on a jury, they're all patients too. And they all have expectations, and their expectations for positions are that they're going to be a kind, caring, and compassionate person. If that comes across from all of you, you're halfway there. Because that's the expectation that jurors have. When you talk to patients, the other thing I always like to remind people is give them the realistic view of things. Sometimes we get busy on the marketing end of things and tell them how wonderful everything is going to be. My daughter's in her last year will be residency, and I keep telling her, don't promise your patients that you're a baby. They don't all work that way. You know, you certainly want to be encouraging and helpful to them, but you also, 50, 60 years ago, childbirth was the leading cause of death in women. You have to have a realistic view that there is a downside to the care that you're providing. Give them reasonable expectations. You know, again, going back to OB, I remember, I'm in this business, I remember the first time our first child, I'm not sure even I recognized how little I was going to see my OB. When you're a first time set of parents, as an OB provider, you want to tell them what to expect when they go in the hospital, because they probably aren't expecting that you might admit them, and then you may not see them for another 14 hours until they're ready to deliver. They need to know that so that they have expectations of what it is. You know, if you're an orthopedic surgeon and you're doing an ACL, you may not want to tell them that they're going to be running the 110 too. Great, maybe they will, but that's not a guarantee. And that's, again, reasonable expectations. They're going to be painful. Those kinds of things are things that patients need to know. And then keep them informed along the way. When things don't go perfectly, we want to let them know that. We want to keep them in the loop in terms of what it is that's happening to them. When things go bad, we'll talk a little bit more about that. But transparency is key. When things aren't going right, you need to talk to them. And you need to let them know what's going on. I never used to bring this one up, but it's become apparent to me that this one is almost as important as the communication with patients. You know, I remember when my wife was going through nursing school, and she was doing her surgical option. She went down and actually was with a surgeon friend who was operating and who later became a friend of mine, who had a bit of a penchant, was an old school surgeon who had a bit of a penchant for temper tantrums, and literally came flying out of the operating room and threw a surgical tray at the wall. It didn't take long for my wife to realize she didn't want to do surgical nursing. But in that whole thing, you can't, you know, back in the 80s, you probably could get away with some of that. You just can't do that now. And if you have patients that are around the area, what do you think the patients are thinking about? If you have a problem with the nurse, if you come in front of the patient and ride the nurse about what they're not getting done, what confidence level do you think the patient has got? That communication level of what you're doing with other staff members carries forward and gives the patient an impression of how you're doing collectively. If you're not giving the impression that the nurses are doing a good job, well, then their impression of the whole system is going south and you with it. And the same is true with the nurses. If the nurses are not giving the impression that you're doing a good job, again, that confidence level of the patient in the system and what it is that you're doing collectively just erodes. Informed consent. So a lot of times I hear doctors say, well, we have the form. I will tell you the form is not your informed consent. The form is, it's a wonderful tool, it's not worth much. It's probably more to satisfy doing commission than it is anything else. Why do I say that? So let's say I've got a surgical case and the question comes down to a known risk. And we have a surgeon that doesn't put anything in the record other than sign the form. And so we bring up and we ask the patient, is this your signature? Yep. You saw the form? Yep. Does it say that all the risks and benefits were discussed? Well, I guess so. And then the plaintiff's attorney comes up and they ask questions about it. They put the form back up again and say, do you remember this? No. And then they'll ask the question, how many forms did you sign when you were in the hospital? And the jury all goes, there's so many forms that people end up signing when they're in the hospital, they don't remember all of it. I mean, I suspect, how many have a mortgage? Who read it? Anyone? You probably, okay, it was maybe a couple. I'm an attorney, I'm kidding. You know, you get in there and you go to the end where you sign and that's primarily what patients do. Especially when they're in a stressful situation to begin with. And that's kind of what juries believe too. The important part about the informed consent is your discussion and your documenting that discussion in the record, not the form. Transparency. This is different. When I first started, you know, the whole concept was, okay, if something goes wrong, just won't say anything. All we're going to do is get in trouble by saying anything. That's changed. Now, what we've realized is that, you know what, we have to look at patients as human beings, and we're human beings. And the concept of that is simple. We need to have them involved in the process. If they feel as though they're not being listened to, those are the patients that sue. If you're engaged and you're telling them and you're talking to them about their outcome, you're expressing empathy to them and walking them through what they're experiencing, they have a degree of comfort in you. They're far less likely to bring lawsuit than if something happens and you walk away. Almost every case where we talk to people afterwards and studies that have shown that, one of the biggest reasons that patients bring lawsuits is they feel like they weren't listened to. Almost 80% plus of cases that we've seen in studies have shown that. So when you talk to patients, how do you do that? That's a skill. And not everybody has the same level of skill in doing that. Providing empathy to patients and what they're going through, whether there's a good outcome or bad outcome, is always good. That's part, again, of being the complete, not just the skill part of it, of being a physician, but being the compassionate provider part of it. That's always important. But when you have a bad outcome, it becomes essential. It becomes essential because you're the one that's guiding them through what's next. And they don't know. This is new. You know, when people come to me when they've been sued, I always call the first time I meet with them sort of the hand-holding session. Because this is new to you. You're out of your environment, just like a patient is when they come to you. And it's emotional to them. It's real to them. And you need to provide the guidance that gets them through that. Part of that is empathy, and part of that is education. And doing that in a skillful way is again, not everybody has those same level of skills. What you don't want to do is say, I'm sorry, this was my fault. Because sometimes that's really not the case. Even if you might feel it to begin with, we take a second look at it and you realize that, well, actually, there's more to it than that. We don't want to go there, but expressing empathy and providing that background and that education to the patient is crucial. You have a really bad outcome, whether you're documenting or you're communicating with the patient, choose your words wisely. Take a deep breath, take a step back, and think about what it is that you're saying. You need to have that sixth sense of, this is bad. What do I need to do to put this in the best position that I can? And if you don't know, there are resources to help you. Whether that's colleagues or administration, risk management, whatever, use the resources that are available. They may be better at this than you are. It's okay sometimes to get some help with these things. Talk a little bit about some cases just from the standpoint of some takeaways that we have. So here you've got a 42-year-old, here's in the ER, chest pain history, onset of 3 days, gives the history to the provider of a smaller community where everybody knows everybody, comes in, provider knows the patient well, specifically said, I was chopping wood and I felt, I ripped it, I pulled up, I was throwing the axe and I could feel this rip across my chest. Okay. So, from a common sense standpoint, this is a done deal, right? From an ER standpoint, we have an answer, except we have a patient who's already self-diagnosed. What we didn't address is the elephant in the room. Their blood pressure at 244 over 154. And we sent him home, and of course he comes back and that didn't make it. This is the self-diagnoser, right? It's easy to fall into that trap where a patient comes in, and I've done it. I mean, I've gone to my own doctor where I came in and I said, well, doc, here's the deal. I've got a very swollen and painful big toe. My dad has a history of gout. My grandfather has a history of gout. My brother has a history of gout. What do you think it is? To his credit, he said, great, I'm going to do a lab on you and see. So he did. But the easy thing to do, right, would be, okay, I have a good relationship with this doctor. He knows what I do. I already think I know what I've got. As it turned out, I was right. But it would have been easy to fall into that trap of letting the patient do the diagnosis instead of you. So here's an example. So this was a strange case years ago. A 20-year-old manic depressive on lithium appears in the ER with his family late in the evening. Do a complete interview. By the time he leaves, there's no grandiosity, there's no suicidal, homicidal ideation, nothing that looks ominous. And so they basically released him, said, you need to go see your psychiatrist in the morning. They'll draw a lithium level. We'll get to what's going on. Middle of the night, there's a call. Goes into the hospital, goes into the system. They talk to a nurse on site. And specifically, the nurse called the psychiatrist on call, and basically they said, okay, well, talking through this is what we'll tell him. This is, at that point in time, mom was comfortable with it, whatever. Well, later that morning, this 18-year-old kid becomes grandiose and jumps into the river and drowns. What didn't we have? We didn't have any record of that call anywhere in the hospital. We didn't have a record from the nurse, we didn't have a record of the psychiatrist, we had nothing to base that on. Ultimately, we were able to get the psychiatrist to testify, we got the nurse to testify. The jury ultimately bought it, they believed it, and they found in our favor. But that case never would have been a case had we had a document that basically showed what the discussion was. We didn't have that. So here's another prime example when you talk about policies. So you got a patient who's had a nephrectomy. They have a standing order basically saying they're supposed to be eyes and nose every shift, part of a policy that exists at the unit. And then, of course, nurses were busy. We didn't get all of those done. Half the shifts didn't have eyes and nose in it. And then when they did, they were delinquent. Well, it didn't matter. I mean, realistically, if you looked at it, they got 2 out of 3 shifts all had normal eyes and nose. you are probably going to be able to say, okay, well, the one that's missing was a problem. On the other hand, it was very easy for the plaintiff's attorney to put the big billboard of the policy on and say, look, this hospital says this is what you're supposed to do, and they just don't do it. So if you have a policy, you need to either follow the policy or you have to explain why you're not following it. Every policy has different types of policies and protocols. You know, whether it's a stroke protocol, a chest pain protocol, just the surgical timeout. If you have those types of issues and those types of things that are there, and you don't follow them, you need an explanation why. Okay? Because otherwise what's going to happen is the plaintiff's attorney is going to put if there's a bad outcome, plaintiff's attorney puts a great big billboard up that's got that policy and show why you deviated from that policy. With a case that we tried just a couple of years ago, 19-year-old appeared in the ER, very, very, very large down weight, about 425 pounds. He's got glucose in the 500s, he's got some blurred vision. It was very clear to everybody there he was initially being diagnosed as diabetic. They sent him over to family practice and set him up with a diabetic specialist, set him up with a nutritionist, and got all the things going. A week later, all of a sudden, he ends up dead. And the question really came down to, okay, well, what did we do to evaluate this patient? What we didn't have in the records was the discussion. We set this kid up with all kinds of different people and made sure that he was taken care of. And we didn't have as a note that talked about, here's what you need to look out for, even though they were there. And so, again, the issue with all of that is always going to be, what kind of documentation do we have? If we need to defend the care later on, what can we do to show that what was done actually got done? We just tried this case back about 3 months ago. 4-year-old came in with Down syndrome, was an asthmatic, not taking med for 2 months, dropped his oxygen sats in the ER. The question really came down to whether or not it was a bacterial or viral pneumonia. Plaintiffs were arguing it was bacterial. We should put them on antibiotics. The reality is that there were no signs and symptoms that made sense with that. But what we were missing was, again, we were missing that documentation of ruling out why it wasn't bacterial. There was a jump to the assumption of why it was viral, but it wasn't. You didn't see in the record the rule out portion of why it was bacterial. Again, we had experts that came in and showed why this didn't make any sense, but I think had we had that documentation of the rule out, I'm not sure that it ever would have become a case to begin with. So lastly, we'll talk just a little bit about some of the things that have happened recently in North Dakota. We've got some good news on what our Supreme Court has done for medical practice, including the cap on damages, and what it's done with peer review. We have a couple of other issues that are not as good, and I've got lots of questions from all over the state on the mess of the abortion statutes that there's no rhyme or reason to that, but we'll talk about that a little bit. So the really good news is this. There was a challenge made to the cap on non-economic damages. And so when we talk about that, non-economic damages are your pain and suffering, loss of enjoyment and the like, those things that there's no real good way of measuring. No, it's one thing if you have somebody who's badly hurt, they come in and they say, okay, well, I lost $82,000 in medical expense that it cost me in the hospital. We can put a number to that. Or I lost 6 months of work and I make $45,000 a year. We can put a number to that. If I ask any of you, okay, your arm hurts, what's that worth to you? Or I can't walk anymore, what's that worth to you? This is what we tell jurors. We give them a jury instruction that basically says you should consider their station in life, how it affects them, and not much more than that, and now go deliberate and tell us what a broken arm's worth. That's what we do. That's where you come back to that question in Minnesota. They do not have a cap. That's where the $115 million came in. How much difference did that make? So let's, for instance, in North Dakota, we have somebody who experiences a bad injury or a death. And we have a bad problem. We need to try and get it resolved and settled. How do we do that? We meet with them and try to figure out what it's worth. In North Dakota, we start with the fact that the most you can ever get, aside from those medical expenses and the wage loss, is $500,000. That's it. In Minnesota, when I do that with no cap, oftentimes it starts at millions because there's nothing to say that you can't get there. It's a big deal. And so it ran up to the Supreme Court, and the Supreme Court, in a unanimous decision, said, no, this is really what we meant. This is perfectly constitutional. It's something we need in this state, and we're going to uphold it. That was truly huge news. The second thing just happened a few months ago that was really good news. So I'm sure most of you in some respects have gotten into some committee, whether it's been a peer review committee or medical executive committee or a department committee. The work that you do there, when you analyze and evaluate cases and evaluate the care that's been provided, is protected under North Dakota law. And it's protected under most states' laws, but it varies from state to state. This is a big deal. Why? Because imagine if you're debating these cases and frankly there's often differences of opinion as to what the appropriate thing to do was. And you talk about that in your committee. Imagine if every plaintiff's attorney can now request that information and say, okay, well, even amongst your colleagues, they didn't think you did the right thing. Who's going to want to be on those committees anymore? Right? This was a big deal. And so the Supreme Court upheld that and said, not only are we going to uphold the sanctity of the peer review privilege, but we're not even going to require that you say who's involved. So it protects the entire process from start to finish. So that was a huge deal. One thing we're trying to get changed that we've been very successful with in Minot, and we've been very successful in Grand Forks. Not so much in Fargo and Bismarck. This will, to most of you, I think this will sound crazy, but it's reality of what's happening in some cases. So everybody's seen medical bills, right? You get a medical bill that says the charges are $38,000 and medical insurance paid $12,000 and there's a deduct of $18,000 and you need to pay $800. Plaintiffs' attorneys are trying to get it so that we don't care how much actually got paid. They want to use that number that nobody cares about that never gets paid to anybody. So how big a deal is this? It's a big deal. Why? I've seen cases where you had somebody who becomes septic and has a month-long stay in the hospital. The DRG for Medicare says we're going to pay $60,000. That's all we're going to pay. The charges are $650,000. So then they come back and want to sue the hospital for $650,000 that the hospital never got, when all that really got paid was $60,000. I mean, it doesn't even make any sense. But believe it or not, there are actually some judges in Fargo and Bismarck that have bid off on that. And so that's one of the things that we're trying to change. And then there's the abortion statute. The abortion statute is an abortion in and of itself. So, I mean, my honest take on it is this. There's an original abortion statute. Then in 2007, there was what was called the trigger statute, which basically was one that was created with the idea that if Roe versus Wade ever changes, this comes into play. Then they did it again in 2020. What's the problem with it? Well, the problem was is that when they created the two new ones, the 2007 and 2021, I'm not sure that the legislators really sat down and analyzed what the effect of this would be in terms of how it relates to the previous one. Why? Because it didn't matter. Until Roe was overturned, it didn't do anything. And so nobody really stopped and checked to see how does this mesh up with what we did before. And it doesn't match. So what really happened? One of the things that I hear all the time is, well, the Dobbs decision in the Supreme Court, basically made abortion illegal in the United States. That's just categorically not true. What it did was it brought the decision back to the states, but unfortunately, when it brought back to the states, it brought up these two trigger statutes those now come into being, which don't have the same language as the original statute. The original statute, and I get questions on this all the time, one of the big topics across the country is ectopic pregnancies. Somebody comes in with an ectopic pregnancy, what do we do? Because technically, the new statute says you can do an abortion if it's to save the life of the mother. Well, usually with ectopics, if you discover it early enough, we're hopefully not at a point where mom's life is in jeopardy yet. If we let it go, they might be. And so you get that gray area of, can we do this or can't we do this? The original statute in North Dakota specifically accepts ectopic pregnancy and said that doesn't count. And so it really puts you in a position where, what is it that we're supposed to do? What we've been talking about, I've talked to Drew Wrigley, who's the Attorney General, a couple of times about it. He recognizes there's a problem. And technically, he's the head law enforcement agent of North Dakota. All the state's attorneys in the state are below him. And he's assured me that nobody will prosecute a physician for treating a woman with an ectopic pregnancy. And I said, well, that's all great, Drew, until you get some cowboy who's deciding he wants to make national news and all of a sudden decides to do this. He said, all of our people want assurance, not just that, yeah, nobody will do this. We want it clear it's not going to be done. And so we've been meeting with a number of different people. Drew Wrigley basically said once that decision was made, the trigger laws are now officially in effect. Then what happened was there was another court that came in that put a stay on that, which means it's not technically enforced right now. So what's happening at this point? The new law hasn't taken effect because of the stay from the judge. I just talked on the way here, I talked again to a good friend of mine who's the executive director of the North Dakota Medical Association. They are frantically drafting legislation to clear this all up. And they have assured me that they will get something. They don't know exactly what it looks like. There's 10, 15 versions floating around right now. But the Medical Association, the Hospital Association, North Dakota ACOG, there are all kinds of players that are all involved in this. I've been involved in it. We're trying to get this all straightened out. So one of the concerns that exists right now with the way the statute reads is that doing an abortion is illegal. That's where you start. Then they created, on this trigger statute in 2020, they made what's called an affirmative defense, which is a bad way of doing this. So essentially what it means is that you're guilty if you do it. You have to prove yourself. It changes the burden of proof, so that you have to prove that you have an exception to the rule. It's bad legislation. And I have every belief that we'll get it changed in the next legislative session, but frankly, it's kind of a mess right now. It's unfortunate that we have legislation that nobody put a lot of time and effort into trying to make it make sense. So overall, what is it that we always tell people? If your patients like you, they're not going to save you. 99% of studies all say the same thing. The best thing you can do to avoid litigation be good to your patient. Communicate with them and empathize with what their situation is. Don't criticize another physician in the record, and communicate not only with the patient, but with the other providers. So, any questions? Yeah.
So, you brought up the instance of a nurse documenting the communication with the doctor. Can you tell me how the nurse could have improved on that communication?
All right, so can you tell me that again?
No, there was an instance.
I'll give you the mic.
Okay. No, there was an instance where you said the nurse was documenting her communication with the doctor, and you said the documentation created some conflict. What's wrong with the communication, or how can you improve on that communication?
Sure. So when you get a conflict with providers who are not necessarily agreeing on the best way to do things, that's the question?
Yes.
Okay. You need to be able to say what it is that you're doing and how you're addressing the situation. If what you're doing in your communication or in your documentation is to essentially say what what someone else is doing is wrong or inappropriate, or that they're not adequately addressing something, you're clearly going to raise questions. And you're better off saying, here's what I know, here's what I saw, here's what I'm doing, and not going down the path of here's why I think what somebody else was doing is wrong. If you have concerns about what someone else is doing, there's better ways to handle that, and that's where the peer review system comes in. The medical records it's about the worst place that you can put grievances among providers, because again, the notion of people doing this to each other that's tantamount to signing the check when you have those in your records. And I won't tell you that it's easy to do. Sometimes if you get called into a situation, it's a bad situation, you're trying to figure out how to document what you're seeing. And it's not easy sometimes to do that. Again, that might be a time where if you're struggling with that, talk to a colleague and talk to risk management and see if they can help you put together a note that minimizes that risk. Anyone else?
Yeah, I was just wondering, what is the statute of limitation for child psychiatry?
For child psychiatry?
Yeah.
So, specifically, psychiatry obviously doesn't have a specific limitation, but children do. And so, generally, the statute of limitations in North Dakota is 2 years from the time of discovery. But with children, that's extended 12 years. So, essentially, the longest that we believe it would exist would be 14 years.
Does it have to do with the age of maturity, like when they turn 21? Because in some places it's like 7 years or 21.
18 years.
18.
And after they turn 18, they only have a year. They would only extend a year beyond that. Jeff?
Not a question, but a comment more than anything. Been doing this a long time, and now with the advent of the electronic healthcare record, and now we have coders who are talking in our ear on a constant basis and telling us what kind of things that they would like us to document better, and they tell us how to document. For example, instead of saying someone has respiratory failure, it has to be acute hypoxic respiratory failure, requiring intubation, mechanical ventilation, et cetera, to make sure that their criteria are met for different things. And so we find ourselves saying things in ways that we would never say to each other on the boards or any other way, except for the way coders want us to speak, so we meet coders speak more than anything else. The corollary to that is also that we're using more and more templated notes, right? You see all kinds of templated notes that all this stuff is being put into the record, and you know that people are looking at it, that they're automatically having their fields inputted into their note, and then they might have 1 or 2 sentences there. I think that the level of communication with those notes is horrible. It if I look at a templated note, I've learned so very little about what's going on with the patient versus somebody who took the time to dictate a note or to type a note and tell me what they think is going on and how they and what they understand is going on with the patient. I think that the burdens of coders and trying to document for billing reasons has really created a lot of hardship for us.
Yeah, I agree with you. And if you have that where they're demanding that you put in that kind of detail that makes it frankly look more ominous than you believe it to be, you really have to go the next step with it. That's what you put in. You need to explain your thinking with it so that there's a rationale. Because if you make it ominous in order to be coded correctly or coded in a way that's advantageous, and it makes it look worse than it is, and you don't put anything more about it, that puts you at risk, right? So I mean, to me, you have to follow that through.
Well, they go to great lengths when we have coding seminars to say, don't put anything in the record that you don't think is actually true, right? So that they don't want to sue the medical record. But they will tell you, though, that if you don't document appropriately, though, and if you don't put the level of acuity that's in there, then you will look like if a patient say they die and you didn't appropriately document, now you look like you missed the boat on a simple pneumonia when maybe they had severe sepsis, the septic shock, and multiple system organ failure. And so they're telling you what to try to document appropriately, but there's still this sort of unseen kind of pressure in a sense to make sure that everything is put in there. But it's also coder speak, which is really bizarre. It's not any way that medical professionals talk about it.
Well, even beyond that, Jeff, when you look at the medical record itself, so when you're doing your inputs, whether it's dictation or you're doing the checking off of things on the computer, have all of you seen records that are printed out? What you see on the screen is vastly different than what comes out when you print everything out. And we've seen, for instance, there are times where the template, the nurse checks a respiratory issue. Well, what comes out of the printed copy is that the patient with respiratory failure, but that's not what they were saying at all. But you click that button and that's what comes out on the printout. And so we've seen that quite a bit where the printout of what gets stated in written form is very different than what the checkboxes appear to be in the inputs. And so, yeah, it is. It's a multiple factor issue. And with the coding stuff, I get it. I mean, I realize that there's a huge difference between reimbursement from different things, and they want to make sure that it's coded adequately, or you're frankly leaving money on the table, right? But if you're coding it at that level, you also need to make sure that the rest of your note appears to match what it is that you're putting on the code level. Because if you don't, and you've got something that's titled ominously and there's no follow-up to evaluate it, that's the worst case scenario, is if you put down something, and the same thing is true with speculative diagnosis. You put in the record, we've seen that before, where somebody puts in the record, well, it might be this, I don't think it is. Well then, if that's in the record, then the next question is, so what did you do to rule that out, right? You thought about it, what did you do to rule it out? That's kind of the worst case scenario, is that if it's in the record as a speculative diagnosis, you did nothing to rule it out, and actually that's what it ends up being. Same way with what you're talking about, I think, Jeff, is if you've got an ominous diagnosis or something that's more of a heightened diagnosis, and there's nothing in the note to match what you've done to address that, I think that's problematic. Any other questions? Guys?
When you get that note and you review and finalize it, you also realize when you put that note into the video version, before it was corrected, before you finalize it, is that available to when they ask to discover the notes? Do you only get the finalized version, or do they actually get all the previous version?
It depends upon how it's set up in the individual record system. It varies. But the audit trail will certainly show it. So the audit trails, if you do the fine-tooth audit trail, you literally can see every keystroke that put in.
But is that discoverable, or is this finalized version that is discoverable?
It is. There's arguments over that, but it generally is.
Randy, can you touch on residents writing progress notes and attending physicians signing off on them, and what are some of the pitfalls of that?
Sure. The note I had up there was a prime example of that. When I talked to the attending said he never really looked at the note. Because if you would have taken that off of it, right? And again, there's the pragmatic aspect of medicine and the reality of what trouble you can get into. With residents, if you are the attending and you're countersigning the note, you need to actually read the note. If you just sign off on it, you're still going to be responsible for it. The case that I mentioned with the 4-year-old, that was exactly the issue. First-year resident got named in the dang case, and he had 3 different family practice physicians who, to their credit, were all wonderful to him. They all basically got up and said the same thing, that this is a really good resident. He did everything we asked him to do. Ultimately, our decision was what happened with this child. This should never have been his responsibility. But the reality is that, I mean, every note that he did was all countersigned by the attendings, as expected, and they're on the hook for it, right? So if you're the attending and you're supervising a resident physician and you're countersigning it, you need to read it and make sure that it's what you're comfortable with. Because if you're not, ultimately you are the one that's going to be responsible for it. And I recognize that all takes time. Any other questions? Yeah?
With our portal system, our patients can go in and read their notes and actually send you messages back to change things in their notes. Does that lead to more litigation, that the patients have better access? And then we also communicate by a portal that asks questions, you go back and forth with them.
I don't think it has. So I'll give you an example. 20 years ago, when I used to do work with Trinity, I would say there were times where we had 20 to 25 cases open at a time. And I would say now we're probably closer to 5, no more than 10 ever at a time. And that's certainly been since the communication portals have been open. So I think in some respects it probably has even helped, because I think the communication has been better. I'll tell you where I think the problem comes in. It has nothing to do with any of you. It's Dr. Google. Everybody thinks they can diagnose themselves now, and so they go on Google and e-medicine and whatever it is that they're looking at, they got it all figured out. And you're secondary to the process. I think that's a bigger problem than the communication portal. I think the communication portal is actually pretty good. Anyone else?
So what do you mean by don't speculate on the causes?
Like with what?
Speculation on the causes of the diagnosis of the injury. You said.
Oh, so that's what I talked about before. So if you're going to, differential, it's a process, right? I mean, you start buying, you focus in, you take in what you know, you take in your diagnostics, and you come to an ultimate conclusion. And ultimately, when we talk about a differential, it's a process, not necessarily the answer. But if you're going to speculate in the record as to a diagnosis, you just want to make sure that you go the next step to rule it out. Because the worst thing I think you can do is if you say, well, it might be this, but then we don't do any kind of testing, we don't do anything in follow-up, we don't do another x-ray, we don't do anything to rule that out. If that comes into being, it's pretty easy then for the plaintiff's attorney to say, heck, look at this, look at your own chart. You thought that's what it was. Well, what did you do to rule it out? You let them walk out the door and didn't do anything else for them. That's what I'm talking about.
And how does that pertain to like radiology reports where some reports will have a complete laundry list of things out there, and you're going to say to yourself, well, how much of this do I have to shake down now? Because it's like, oh my God.
Yeah, I hear that a lot too. And not to pick on the radiologist, but then you also have the first line of, the image was suboptimal, however, right? So they're covering their tail too, right? I mean, they're basically laying that out. I know some surgeons that have talked to the radiologists said, don't put that in there. But I think if you have a concern with that, talk to radiologists and tell them, put in that you think follow-up is needed, but don't tell me everything you think it is, because it just makes more of a problem with me. I know I've had surgeons that have talked to radiologists and specifically told them, don't put that in. So to me, I think, again, that's sort of a communication issue to make sure that your team is all on the same page. Because yeah, you're right. If you've got 9 things that the radiologist will list off, and you don't think 7 of them have any implication at all, now, truth be told, they also will finish it with clinical correlation should be done, right? So you're the clinical correlation. And I think you could explain that you don't see any merit to any of those based on your clinical analysis. So I don't think you have to chase all of them. I think you can kind of isolate that. Yeah?
What are your thoughts on legal consequences on either party, defendants or the other side, especially when a patient or a patient's family secretly or obviously recording the encounter, audio recording or visual, both, whichever.
So, I'm sorry, I had trouble hearing you.
Like when the patients or the patient's family are actually recording the encounter, whether in the hospital or in the clinic,
Okay.
both audio recording or video. What are the legal consequences that we can encounter any experience?
Without your knowledge.
Yeah. Sometimes, obviously, they're recording me, I know, or sometimes secretly. So either way.
Yeah. Well, technically, under North Dakota law, if you're a party to a conversation, you can actually record it. We obviously encourage not having that done. For a number of reasons. Among them are, how easy it is to doctor a recording now, if you want to. You can take anything and change it, and so there isn't really much that we can take that will be gospel, even with the recording. I mean, we've seen recordings come back that are not accurate, and the only thing I can tell you with that is that we strongly encourage that we don't want recordings taken. We just think that that's not good practice, and it frankly chills the relationship between the patient and the physician.
What if the patient is recording us? What are the consequences of that?
I don't think we know what the consequences are. I think it depends on what happens.
Okay.
Technically, can they do that? Is it illegal? It is if they're a part of the conversation. We can't necessarily stop that. So I'll give you an example of that. We've strongly discouraged videotaping deliveries, for example. And again, sometimes these things are marketing too, right? We've had orthopedic surgeons that wanted to record a laparoscopic repair, and then they give it to the patient, or they take pictures of it, or whatever. So there's different aspects of that from our side of things too. In general, I don't think they're helpful usually. It's kind of like when I have physicians that like to think that, if I could just explain myself, they'd understand, they wouldn't sue me. I can tell you that doesn't work. We think that will always be the answer. A lot of physicians do. It never quite works that way. And radiologists and pathologists are in the worst position of any physicians from a retrospective review standpoint. Why? Well, Dr. Billings, if you see a patient and you talk to him and you feel their belly and you do all that, nobody can tell what you saw and what you did and what you thought. They don't have that tactile feel of what you did in the clinic room, right? But for a pathologist, anyone can look at the slide and see exactly what you saw. For a radiologist, anyone can look at the MRI and see exactly what you saw at the time. There's no hiding it. And unfortunately, for radiologists, if you know where it's at, and you know that there's a problem that's discovered 3 years later, it's always easy with the retrospectoscope to go back in time and find something that looks suspicious. That's the hard part for both pathology and radiology, is that we don't have that same advantage. When you do videos or photographs, that's an advantage we lose because now you can see them. Anyone else? Yeah.
Following up on the subject, I had a situation where circumcision, dad pulled up his phone, wanted to record, and I said, no, please, just go with the phone. So my question now is, do I have legal right to have asked him not to?
Get at that.
Yeah.
Trinity policy that we know about.
Yeah.
Yeah, we can. Okay. And we do often. I encourage that. I mean, like I've said, we've encouraged on the lead floors, if you're going to do any kind of a video, we'll allow it of something other than the actual delivery. Or you couch it in a different way. So, for example, if we have video taken for peer review purposes or for educational purposes, you keep it without identification.
This is more like that.
Yeah. Okay.
We found I wanted to take, video record his child being circumcised. So like,
Yeah. No,
I don't know why I told him, hey, okay, but please, keep it away your phone.
No, and you can tell them this is not something I allow in my office.
It's against the Trinity policy.
What else? All right, well, thank you very much. It was good to see a lot of you that I haven't seen for a while again.
Okay.